Hey, welcome back to Not So Complicated, and this is day 9 clinical case discussion 9 like we used to do, and today is the case of hernia and you have to diagnose which hernia it is, and it is either complicated or uncomplicated. So here is the case. The case goes like this. A 48-year-old male presents to the emergency department with a 12-hour history of severe right groin pain, nausea and vomiting. He noticed a bulge in his right groin 2 months ago, which was reducible until yesterday. He denies fever, trauma, or recent heavy lifting. His medical history includes obesity, BMI, that is body mass index 34 kg per meter square, and type 2 diabetes mellitus treated with metformin. His temperature is 37.4 degrees Celsius, blood pressure is 140 by 90 mmHg, slightly hypertensive, and pulse is increased 110 by per minute, and respiratory rate is 20 per minute. Physical examination reveals a tender, non-reducible 4 cm mass in the right inguinal region, with overlying erythema, right? And bowel sounds are hyperactive, and there is mild abdominal distension. Laboratory studies show white blood cell counts 16,000 per microliter, which is slightly infectious, with leans to our slightly infection case, and there is 80% of neutrophils, and hemoglobin 13.5 gram per deciliter, platelets 250,000 per microliter, serum creatinine is 1.2 mg per deciliter, which is in borderline, high borderline, and lactate is 3.5 millimole per liter, which is increased, so it signifies that somewhere here is having anaerobic reaction. To have anaerobic reaction, there must be ischemia, right? And to be the ischemia, there must be obstruction or strangulation kind of thing. So abdominal x-ray shows air fluid levels in small bowel, no free air. There is no free air, there is air fluid levels, right? And the USD shows non-reducible inguinal hernia with thickened bowel wall, and there is no Doppler flow in herniated contents. You have to remember this. There is no Doppler flow in herniated contents. So which of the following is the most likely diagnosis? Indirect inguinal hernia with incarceration, direct inguinal hernia with obstruction, femoral hernia with strangulation, incisional hernia with incarceration, hydroil with secondary infection. So this is a very narrow spectrum of alternatives that we have. So to diagnose this case, we have to debunk each of the options in details and establish a differential diagnosis and go to the provisional diagnosis, right? So here is the first option that we have, indirect inguinal hernia with incarceration. So let's debunk this. It actually occurs through the internal inguinal ring, and which follows the spermatic cord in males or round ligament in females, and then it goes to the to above the inguinal ligament. It is common in males and often congenital, entering the scrotum in advanced cases. So basically in advanced cases it enters scrotum, but in this case it is not associated with scrotal case, right? So it is in right inguinal region, and ultrasound findings also doesn't show any Doppler flow, and it has thickened bowel, and elevated lactate indicates strangulation. So there must be strangulation in place of incarceration, like this case, like this option. And so it is very rare that there is lower strangulation risk in indirect hernias, almost 5 to 10% than femoral hernias due to a wider canal. So basically this might not be the case. This is very unlikely, and also this patient's groin mass is non-reducible and tender, suggesting incarceration, that is trapped contents. Okay, that is it, right? And the second option we have here is direct inguinal hernia with obstruction, and actually a direct inguinal hernia protrudes through Hasselback's triangle, and Hasselback's triangle is actually made up of rectus abdominis muscle medially, and inguinal ligament inferolaterally, and superiorly there are inferior epigastric vessels, and that is what the triangle makes. And the contents protrude from this triangle due to abdominal wall weakness. It is less likely to incarcerate or strangulate, that is less than 5% risk due to wider defect. And also these patients have non-reducible mass, erythema, and obstruction, suggest a complicated hernia, and this is a case of complicated hernia. But direct hernias rarely cause strangulation due to their broad base. It is very rare, right? So this also might not be the case. And also the ultrasound, that is no Doppler flow, thickened bowel, and lactate indicates ischemia, more consistent with femoral hernias narrow canal. So these two options are leaning towards femoral hernia, right? The masses location, that is inguinal region, could fit here, but direct hernias typically present as reducible bulges in older males, not acute emergencies. And obesity is a risk factor, but the clinical picture leans towards femoral hernia. So this is very highly unlikely. And the third option we have is femoral hernia with strangulation. This might be the case. So let's debunk this. Actually, the abdominal contents protrude from the femoral canal below the inguinal ligament. So the location fits in here, that is right inguinal, right groin plane, right? So basically below the inguinal ligament, lateral to the pubic tubercle, and the incidence is greater in female than males, but in males it can also occur, especially with risk factors like obesity, BMI 34 kg per meter square. And also this patient's non-reducible tender right groin mass with erythema, nausea, vomiting, and hyperactive bowel sound suggests a complicated hernia, and USC shows thickened bowel wall, absent Doppler flow, which indicates strangulation, and that strangulation compromises blood supply, leading to tissue ischemia, right? And the elevated lactate level reflects anaerobic metabolism, as I talked about it earlier, from ischemic bowel, and air fluid levels on X-ray confirm small bowel obstruction. So basically, the acute 12-hour onset leukocytosis, that is 16,000 per microliter, and non-reducibility distinguishes strangulation from incarceration, that is trapped contents without ischemia. So the difference between strangulation and incarceration is that there is trapped contents in both of these cases, but there is ischemia in strangulation, but not in incarceration. So this is very highly likely. And in the femoral hernia case, the abdominal contents like preperitoneal fat and omentum and bowel gets protrude out from the femoral ring, as is shown in the figure, right? So this is the case. This might be the case. This is our diagnosis probably. Let's see other options. The fourth option we have is incisional hernia with incarceration. So incisional hernia actually occur at prior surgical sites due to fascial weakness, often after abdominal procedures, but there is no history of any abdominal surgery in this case. So basically it might not be the answer, and they can incarcerate, causing pain and obstruction, but this patient has no surgical history, as I said earlier, ruling out incisional hernia. So the groin location, that is inguinal region, is inconsistent, as incisional hernias typically occur at midline or laparotomy scars, like I have shown in here. In midline there is incisional hernia, and also there is a scar, right? The scar is of pre-surgical, surgical history. And also the ultrasound findings and lactate suggest strangulation, which can occur in incisional hernias, but the anatomical site and lack of surgical history make femoral hernia more likely. So this is also excluded from our options. The last option we have is hydrocele with secondary infection. So a hydrocele is actually a fluid collection around the testis, congenital or idiopathic, and it presents as a painless scrotal swelling, illuminating on exam. Like you can see here, non-communicating hydrocele and communicating hydrocele. These are two different types of hydrocele, and the difference is entirely clear in the picture right there. And also, so non-communicating hydrocele is basically limited to scrotum, but communicating hydrocele is not. And it does not cause obstruction or systemic symptoms. Secondary infections are rare, but they could cause erythema and tenderness. But this patient's non-reducible groin mass, ultrasound findings, and obstruction indicate a hernia. Ultrasound findings, as I said earlier, that is non-reducible hernia, thickened bowel, no Doppler flow, and also hydroceles are confined to the scrotum, not to the inguinal region, and lack bowel involvement. So this is very highly unlikely. So what is our diagnosis? The diagnosis is femoral hernia with strangulation. Also, there is a difference between hernia and hydrocele. I have attached it here. So in hernia case, there is wide neck, so viscera herniates, right? So, and in hydrocele there is narrow neck, so only peritoneal fluid collects. And in hernial cases, there is a history of inguinal swelling on crying or coughing, and there is a history of scrotal swelling with diurnal size variation in hydrocele, and this is non-reducible. But in hernia, it is often completely reducible, and hydrocele is actually fluctuant, and then it is transilluminant. That is, it shows a color. It shows light. it shows color like reactions when on examination, that is transillumination. This is a classic characteristic feature of hydrocele. So the diagnosis we developed is femoral hernia with strangulation. What actually happens to cause this? The mechanism is that a section of intestine bulges through the ring, right, and it pushes out a hernial sac of peritoneum covered by femoral septum, like this in the figure, the red marks that is here. And also it bulges downward through the femoral ring into femoral canal, then it pushes forward through the saphenous opening, and finally turns upward around upper margin of saphenous opening. That is what happens in the case of femoral hernia. And there are other types of hernia also. I have attached the picture to clear the confusion that we occasionally have. So epigastric hernia, it is in epigastric region, lateral hernia in lateral region, umbilical hernia in periumbilical regions, and inguinal hernia is that in upper region. Inguinal hernia can be direct or indirect, and there is incisional hernia, which is often associated with scar and a surgical history, as I said earlier. And the femoral hernia is often below inguinal ligament. So femoral hernia is below inguinal ligament, and then inguinal hernia is above inguinal ligament. You can remember like that. So basically the clinical features of femoral hernia include groin swelling, often is small, groin pain on exercise, sometimes difficult to distinguish with inguinal hernia, and on examination there is we have to put a fingertip above over or above pubic tubercle. So pubic tubercle, and inguinal hernia is above and medial, but femoral hernia is below and lateral. That is the difference. So it is often irreducible due to its curved course, right? And there can occur obstruction and strangulation rate, and that is very high. In this case, that is up to 40%. And in a differential diagnosis of femoral hernia includes lymph LN, and also saphenous varix, and which causes thrill on cough, disappears on lying down, ectopic testis, and psoas abscess. Here you can look at this MRI, where in radiography you can see the hernia cases in there. You can clearly see in the right upper region there is a hernia, and also then we can now go to the management of femoral hernia, right? So basically, let's go to our site. Immediate surgical intervention is required, and surgical intervention, emergency surgery that we do is by a open approach. Example, low inguinal or McVitie's incision that we do, and to assess bowel viability, and we have to reject necrotic bowel if present and perform primary anastomosis. And then we have to repair the femoral canal using mesh if there is no contamination, or suture-based techniques, that is Cooper's ligament repair, and also laparoscopic repair is avoided in strangulation due to obstruction and ischemia. And that is how we do emergency surgery. There is open repair and laparoscopic repair. I have attached it, and there we can use open mesh too, but we can also do suture only, but that depends on the cases how likely that we can do. And the preoperative preparation is administer IV fluids, normal saline 1 to 2 liter bolus to correct hypovolemia, and also broad spectrum antibiotics, piperacillin tazobactam 3.375 gram IV to cover enteric flora and prevent sepsis, and NG tube for decompression if vomiting persists, right? So hypovolemia is due to vomiting because he has the history of vomiting, and hypertension is to counteract that hypovolemia. That is a reflex hypertension. And then we can do the supportive care. We have to do the pain management like IV morphine 2 to 5 mg Q per hour, or fentanyl 50 to 100 mcg Q 1 hour for severe pain, titrated response, right? And we have to monitor lactate. We have to recheck lactate post-surgery. Persistent elevation suggests ongoing ischemia or sepsis, and the metabolic support we can do is monitor glucose, diabetes history, because we have diabetes history, and electrolytes. We have to correct hypokalemia if there is present. So femoral triangle, the contents of femoral triangle, we can remember that with a mnemonics called navel, that is femoral nerve, femoral artery, femoral vein, then empty space, that is femoral canal, and L for lymphatics, that is navel, and it is from lateral to the medial region. So lateral to medial, there is femoral nerve, femoral artery, femoral vein, empty space, and then lymphatics. And also the postoperative care of femoral hernia with strangulation. There is we have to do wound care, monitor for infection, especially given erythema and diabetes, that is increased risk, and we have to change dressings daily. Bowel function, advanced diet. Once bowel sounds normalized, typically 2 to 3 days. Watch for ileus. Common post obstruction is ileus, right? And then complication surveillance, monitor for wound dehiscence, abscess or anastomotic leak, fever, leukocytosis, CT abdomen if suspected. And here is another figure here. This is Lichtenstein repair of femoral hernia. We will talk about its details in our study sessions, not in the clinical case discussion. And the management of femoral hernia, in long-term management, we have to do risk factor modification, that is we have to counsel on weight loss, BMI 34, and to reduce recurrence risk, we have to recommend dietary changes and exercise post recovery. Follow up, clinic visit in 1 to 2 weeks to assess wound healing, then 3 months for hernia recurrence, and recurrence rate is less than 5% with mesh repair. And also the prognosis is prompt surgery is 90% is greater than 90% is survival. Delayed intervention risks bowel necrosis, sepsis, or mortality. That is 10 to 20% is in strangulated cases. That is how we wrap up our clinical case discussion of day 9. We will do another clinical case discussion tomorrow. So subscribe for our next cases and also study with me sessions. And if you have any special requests, you can comment it down. Thank you for staying with me.